If you are a woman over 60 and you have been eating less, moving more, cutting carbs, skipping dessert, trying every diet that your friends recommend, and that belly fat is still sitting right there, stubborn and unchanged, I need you to understand something important before you blame yourself for one more day. It is not your willpower. It is not your discipline. And it is almost certainly not your calories. What is happening to your midsection after 60 is driven by a specific hormonal shift that most doctors spend less than 3 minutes discussing during a routine checkup. And without understanding this mechanism, you can exercise every single day and eat like a nutritionist and still watch your waistline expand. Today, I am going to walk you through exactly what is happening inside your body, what the research actually says, and the specific steps that the evidence supports for addressing this. Not generic advice, but the precise biological levers that matter for women in this stage of life. I'm Dr. Steven, and this channel exists to bring you the latest peer-reviewed research on health for adults over 60, translated into information you can actually use. If you are not subscribed yet, please do that now, because what we are covering today is one of the most misunderstood and most consequential changes in the female body after menopause. Let's start with the biology, because once you understand what is actually happening, everything else will make sense. The hormonal shift nobody prepares you for. For most of your adult life, estrogen was quietly doing something remarkable that had nothing to do with reproduction. Estrogen actively directed where your body stored fat. In younger women, fat tends to accumulate in the hips, thighs, and buttocks, the classic pear-shaped pattern. This is not random. Estrogen actively suppresses fat storage in the abdominal region while promoting it in the lower body. Then menopause arrives. Estrogen levels drop by roughly 80 to 90% compared to peak reproductive years. And when that hormonal signal disappears, fat distribution changes fundamentally. Your body does not stop storing fat. It simply stops following estrogen's instructions about where to put it. Without estrogen's influence, visceral fat, the deep abdominal fat that wraps around your internal organs, becomes the body's preferred storage site. A landmark study published in the journal Obesity reviewed data from over 1,800 women across the menopausal transition and found that even women who maintained the same body weight and calorie intake gained an average of 10 to 15 pounds of abdominal fat over the menopausal transition. The scale did not always change dramatically, but the composition and location of fat shifted substantially. This is not a cosmetic issue. Visceral fat is metabolically active tissue. It produces inflammatory compounds called cytokines and adipokines that drive insulin resistance, raise blood pressure, and increase the risk of cardiovascular disease. The belly fat you are struggling to lose is not just sitting there. It is actively generating inflammation throughout your body. Comment below right now and tell me, have you noticed your body changing shape even when your weight stayed the same? I want to understand how many women in this community are experiencing exactly this because the patterns matter. The second hormone making everything worse, cortisol. Here is where it gets more complicated. And this is the part that most conversations about menopause and belly fat leave out entirely. When estrogen drops, your body becomes significantly more sensitive to cortisol, the stress hormone. Estrogen had a buffering effect on cortisol's impact on fat storage. Remove that buffer and cortisol's influence becomes far more pronounced. Here is why this matters. Cortisol tells your body to store fat specifically in the abdominal area during times of stress. It is an ancient survival mechanism. Your body interprets stress as a sign that resources may be scarce, and it stores energy close to your vital organs where it can be accessed quickly. For a woman over 60, cortisol is being elevated by multiple sources simultaneously. Poor sleep and sleep quality declines significantly after menopause, raises cortisol. Chronic low-grade inflammation, which increases with age, raises cortisol. Blood sugar fluctuations raise cortisol. Even under-eating and over-exercising, two things many women do when they cannot understand why the weight is not moving, raise cortisol. A study published in the Journal of Clinical Endocrinology and Metabolism found that postmenopausal women had measurably higher cortisol reactivity than premenopausal women of the same age and weight. Their cortisol levels spiked higher in response to the same stressors and took longer to return to baseline. The researchers specifically linked this amplified cortisol response to increased visceral fat accumulation independent of total calorie intake. This is why the conventional advice, eat less and exercise more, can actively backfire for women in this group. Aggressive caloric restriction is a physiological stressor. It raises cortisol. And for a postmenopausal woman whose cortisol system is already hypersensitive, that stress signal tells the body to hold onto abdominal fat more tightly, not less. Let me tell you about Patricia. She was 63 years old, a retired nurse, and one of the most disciplined people I have worked with. She had been eating 200 calories a day for 8 months. She was walking 45 minutes every morning. She had eliminated alcohol, processed food, and almost all sugar. She had lost 4 pounds. 4 pounds in 8 months of what most diet programs would call perfect compliance. When we reviewed her full picture, 2 things stood out immediately. Her sleep had been severely disrupted since menopause. She was averaging 5.5 hours a night. And her cortisol pattern, measured through a morning saliva test, showed levels that were 40% above normal range. Her body was in a chronic stress state, and every calorie she was not eating was another signal telling that cortisol system to protect those abdominal fat stores. The insulin resistance connection. The third piece of this puzzle is insulin resistance, and it connects directly to both estrogen loss and cortisol elevation. Estrogen plays an active role in maintaining insulin sensitivity in muscle tissue. When estrogen drops, muscle cells become less responsive to insulin, the hormone responsible for moving glucose out of the bloodstream and into the cells where it gets used for energy. When your muscle cells become insulin resistant, glucose stays in the bloodstream longer. Your pancreas responds by releasing more insulin, and chronically elevated insulin has one very consistent and well-documented effect. It directs your body to store fat, and it specifically inhibits the breakdown of existing fat stores. A comprehensive review published in the journal Climacteric, one of the leading journals in menopausal medicine, confirmed that postmenopausal women show significantly higher rates of insulin resistance compared to premenopausal women of comparable weight and activity levels. The researchers estimated that the hormonal changes of menopause alone, independent of aging, diet, or lifestyle, account for a meaningful increase in insulin resistance that directly fuels visceral fat accumulation. Here is what that means practically. You can be eating a perfectly reasonable diet, but if your cells are not responding to insulin efficiently, the glucose from every meal you eat is being managed by an impaired system. Blood sugar runs higher, insulin runs higher, fat breakdown slows, and abdominal fat accumulates regardless of what the food tracking app tells you. Have you had your fasting insulin checked recently? Not just your blood sugar, but your actual insulin level? Most routine panels do not include fasting insulin. Ask your doctor specifically for this test. Fasting insulin above 10 microunits per milliliter in a fasting state suggests insulin resistance, even if your blood sugar appears normal on standard testing. That number tells a story your fasting glucose alone does not. What the research actually supports for women in this stage. Now let me tell you what the evidence says actually works, because the answer is not the same as what works for a 35-year-old woman or a man of any age. The first intervention is protein, and the amount most women over 60 are eating is significantly too low. When estrogen drops, muscle mass begins declining at an accelerated rate. This is called sarcopenic obesity, in a situation where body fat is increasing while muscle is simultaneously decreasing. Muscle tissue is your primary site of glucose uptake. The less muscle you have, the worse your insulin resistance becomes, and the more easily fat accumulates. Research published in the American Journal of Clinical Nutrition found that postmenopausal women who consumed at least 1.2 grams of protein per kilogram of body weight daily maintained significantly better muscle mass and insulin sensitivity compared to those eating the standard recommendation of 0.8 grams per kilogram. For a 150-pound woman, 1.2 grams per kilogram means roughly 82 grams of protein per day. Most women in this age group are eating 45 to 55 grams. That gap matters enormously. Spread your protein across every meal. Do not save it all for dinner. Research on muscle protein synthesis shows that distributing protein intake evenly, roughly 25 to 30 grams per meal, produces significantly better muscle maintenance outcomes than consuming the same total amount unevenly. The second intervention is resistance training, specifically. Walking is valuable. Cardio supports cardiovascular health. But for the specific problem of postmenopausal belly fat driven by insulin resistance and muscle loss, resistance training, lifting weights, using resistance bands, or performing body weight exercises that genuinely challenge your muscles is what the evidence most consistently supports. A 2022 meta-analysis published in the International Journal of Environmental Research and Public Health analyzed 24 randomized controlled trials of exercise interventions in postmenopausal women. Resistance training specifically, not cardio, showed the strongest and most consistent results for reducing visceral fat and improving insulin sensitivity in this population. The researchers found that even 2 sessions per week of moderate resistance training produced measurable reductions in abdominal fat over 12 to 16 weeks. You do not need a gym. You do not need heavy weights. Bodyweight squats, wall push-ups, resistance band rows, and step exercises done consistently and with enough effort to feel genuinely challenged produce real results. The third intervention addresses cortisol directly. This is where sleep becomes non-negotiable and not optional lifestyle advice. A study published in the journal Sleep found that women over 60 who averaged less than 6 hours of sleep per night had 22% more visceral abdominal fat than those sleeping 7 to 8 hours after controlling for diet and exercise. Poor sleep elevates cortisol. Elevated cortisol drives abdominal fat storage. This is a direct documented biological pathway. If you are not sleeping well, address that before adding more exercise stress to your system. Cognitive behavioral therapy for insomnia, known as CBTI, is now the first-line recommendation from sleep medicine specialists and consistently outperforms sleep medications in studies without dependency or morning impairment. What about hormone therapy? This question comes up in every conversation about postmenopausal weight, and I want to address it directly because you deserve a clear, honest answer. The research on hormone therapy and visceral fat is genuinely supportive. Multiple studies, including a 2019 review published in Menopause, the Journal of the North American Menopause Society, found that women who used estrogen-based hormone therapy in the early postmenopausal window showed significantly less visceral fat accumulation compared to women who did not. Hormone therapy appears to partially restore estrogen's fat distribution signaling. However, hormone therapy is not appropriate for every woman. Women with a personal history of certain cancers, blood clots, or specific cardiovascular conditions may not be candidates. The decision requires a thorough individual evaluation with your physician and should be based on your complete health picture. What I want you to take away is this. If your doctor has dismissed this conversation without a thorough discussion of your individual risk profile and current research, you are entitled to ask for a more complete conversation or a referral to a menopause specialist. The science on this has evolved significantly in the past decade. The exact steps to take this week. Here's precisely what to do with everything you have just learned. First, request a full hormonal and metabolic panel at your next appointment. Ask specifically for fasting insulin, not just fasting glucose. Ask for a cortisol level. Ask for a comprehensive thyroid panel because thyroid dysfunction, which is extremely common in women over 60, compounds every single mechanism we discussed today. Second, calculate your daily protein target. Take your weight in pounds, divide by 2.2 to get kilograms, then multiply by 1.2. That is your daily protein goal in grams. Start tracking for 1 week to understand where you currently stand relative to that target. Third, add 2 resistance training sessions per week. Start wherever you are. 10 minutes of bodyweight exercises done consistently twice a week is more effective for visceral fat than sporadic intense exercise. Build the habit before you build the intensity. Fourth, treat sleep as a medical priority. Set a consistent sleep and wake time 7 days a week, including weekends. Keep your bedroom cool and completely dark. If sleep remains disrupted despite these measures, ask your doctor for a CBTI referral or a sleep study to rule out sleep apnea, which is significantly underdiagnosed in women. Fifth, reduce the stress on your cortisol system intentionally. This means not eating at a severe caloric deficit. A deficit of 200 to 300 calories per day is sustainable and does not trigger significant cortisol elevation. A deficit of 600 to 800 calories per day in a postmenopausal woman with already elevated cortisol is likely working directly against your goals. Before making significant dietary or exercise changes, please speak with your physician, particularly if you are managing cardiovascular disease, diabetes, kidney disease, or osteoporosis. These are evidence-based general guidelines drawn from published research and are not a substitute for personalized medical care. The belly fat that is frustrating you is not a reflection of your effort or your discipline. It is the visible result of a specific hormonal environment that your body moved into, one that your doctor may not have taken the time to explain in a way that was actually useful. You now understand the mechanism. Estrogen loss shifts fat storage to the abdomen. Cortisol hypersensitivity locks it there. Insulin resistance feeds the cycle. And the interventions that address those specific mechanisms, adequate protein, resistance training, sleep, managed stress, and an honest conversation about hormone therapy, are meaningfully different from generic weight loss advice? Comment below with one of these 3 responses. Comment protein if you are going to start tracking your protein intake this week. Comment sleeping if sleep is the piece you know you need to address. Or comment sharing if someone you love needs to understand why this is happening to their body. If this gave you something your doctor has not explained, please subscribe because next week we are covering the specific thyroid pattern that affects millions of women over 60 and consistently gets missed on standard blood panels, even when the results come back labeled as normal. I'm Dr. Steven. Take care of yourself. You have earned real answers.